Hello everybody. Over the next few minutes we will discuss how to engineer imaging through the understanding of clinical needs, and I will try to show you that imaging is a biomarker with the potential to promote the quality of care at every step of a patient's journey. I'm going to focus on cancer patients in this particular instance, from diagnosis to death. I'll try to show you that care priorities and clinical needs change as a patient traverses their journey from diagnosis to death, and that means thinking about diagnosis, survival, and the quality of life. And I'm going to show you that building clinical value is a multi-step process that goes beyond just regulatory approvals, and remember that radiological value is not the same as clinical value, and that to show you that objectivity via quantification will enable the integration of imaging with other biomarkers, serum biomarkers, etc., to build clinical value in order to advance clinical care. So here are my disclosures. Now we're going to take the cancer perspective because we know that the global cancer burden is increasing and the global cancer spend is also increasing. But it's important to remember that scaling up of imaging in both low and middle income countries as well as high income countries would avert millions of deaths and yield benefits of trillions of dollars. So this is a really important subject. And I've also picked cancer because there is a spectrum of disease, and for some patients evolution drives an increasingly aggressive phenotype and tumor resistance that eventually leads to death. So there'll be some patients with cancer who will never develop clinical symptoms. There are other patients who can be cured, and other patients in whom no matter what you do they will die, and which means that there is a great deal of complexity. So there are a number of challenges thinking generally about cancer. One is the early detection of the aggressive disease to save lives. Large heterogeneous outcomes of patients. So as I said, some cancers don't kill, some can be cured, some will never be dangerous, but there is unstoppable Darwinian evolution in many patients. There's an increased complexity of the pathways driven by a rapid pace of change of knowledge and science, and increasing pressures on healthcare resources. So the current paradigm, which is a one-size-fits-all paradigm, needs to be gotten rid of to a new paradigm, which is precision oncology, where we want to treat the right patient at the right time for the right duration, and this will be based on diagnostic, prognostic, and predictive biomarkers. So what are biomarkers? Biomarkers are measured indicators of either normal or pathological processes. In other words, biomarkers don't tell us about how a patient feels or functions or their survival, and there are a number of biomarkers, as you can see on the right hand side. I'm going to stick to these three highlighted biomarkers: a diagnostic biomarker, a prognostic biomarker, and a predictive biomarker. So when you have a diagnostic biomarker, you have a group of patients with heterogeneous outcomes, and what we'd like to do is to have prognostic and predictive biomarkers that enable us to separate these patients. So if you have a prognostic biomarker and the prognosis is good, in other words you have indolent disease, you may not need any treatment. If you have a prognostic biomarker that says somebody's going to do really badly, you may want to think of an alternative therapy to what you are going to consider. A predictive biomarker is used for the usual patients. So a prostate cancer patient, do you use focal therapy, do you use radiotherapy, do you use surgery, or do you use androgen deprivation therapy alone? Multiple choices. Which is the best for which patient? So predictive biomarker can help you decide which treatment is best. A predictive biomarker can also say this patient has more aggressive disease and you need to intensify the therapy. So something and something else. So you can see how these prognostic and predictive biomarkers help us to separate patients and in terms of their therapy choices. The other thing to remember is that patients' clinical needs and priorities change as they go through their cancer journeys. Now here is the prostate cancer journey. So on the top left you can see suspected cancer, on the right hand column rest in peace, death. And patients will go along this journey and take different routes, a bit like Google Maps if you like. Okay, and imaging can help direct patients or classify patients into these different groups and therefore help manage these patients within these different groups as they progress from left to right. Clearly, at the beginning, your quality of life is important. If you have a cancer, then your quantity of life becomes important because you are asking the question, how long do I have to live? Towards the right hand side where you have incurable disease, at that stage we are talking about quality of life as well. So you can see how quality, quantity and quality of life changes as you travel from left to right. Now what you have to remember is that new therapy paradigms can only emerge by a deeper understanding of each station within a journey or each state of a clinical journey. So when you start to think about whatever pathway of cancer that you are interested in, you need to have a very precise idea of what is the clinical scenario and the pathological state, what's the problem in the categorization of each state, what the clinical needs are and what the clinical priorities are for patients, what is the role of imaging to promote what's going on at the moment, which is standard care, what could imaging do to promote precision care now and in the future. So let's take the example of a suspected prostate cancer patient. Now, in this type of man, there are men with a very low likelihood of a clinically significant cancer and a very high likelihood of clinically significant cancer. So you have patients with a raised PSA typically, or a person who's had a previous negative biopsy, or there's a family history, genetic mutation in the house. One of the biggest problems we have with diagnosis of suspected cancer is we have overdiagnosis and overtreatment, and we have underdiagnosis and undertreatment. So for example, we know that the PSA test isn't great when it's normal. So if you have a screen detected population where the prevalence is about 4%, about half the cancers have a normal PSA. Interesting. In secondary screening, where you have a raised PSA, then we know that the prevalence is not 100%, it's between 20 and 50%. And even in these patients, most will not die of the prostate cancer. So we have loads of patients that we diagnose with indolent disease that will never cure patients. So you can see how we begin to develop an understanding of the problems in the categorizations. So what could be the role of imaging in identifying or promoting current care or standard care? So we want to know what is the cause of the raised PSA initially. Is this due to significant or insignificant disease? If he has significant disease, where is the most deadly part of the cancer? How do I biopsy that area? So a solution could be something like a multiparametric MRI. So in this multiparametric MRI, you can see that large cancer anteriorly in the left peripheral zone. And what we can do then is to apply this solution to a biopsy. And if you did that, this is the benefit that you would get. So about a third of men would avoid a biopsy completely. You would decrease the number of cancers with indolent cancers, which is worth having, by about 10%. But you can see that you would not impair the detection of clinically significant disease as a group compared to the standard pathway, which is shown on the left-hand side. So these are the benefits. The problem is, if you were to implement this, there would be a number of new challenges, and these challenges are shown here. So a steep learning curve, a large inter and intra observer variability of radiologists. Excuse me for a second. Now you can innovate around this with automation of data acquisition and automation of radiologist reporting using an AI system, for example. This would get rid of many of these problems. However, it doesn't get rid of all of the problems, and some problems are still remaining, in which case you have to think again about what might be the imaging solutions for the current residual problems. So you can see that you have this continuous need for innovation in trying to solve problems in this particular instance, and that applies equally to other areas. So as you think about engineering solutions, there are a number of other things to consider. First of all is, what are the biases of these new solutions? What are the care impacts? And remember that just because you change management, you don't necessarily benefit patients. How do you build clinical value? What is the regulator view? And how do you integrate biomarkers to optimize benefits and reduce harm from false results? We'll just discuss a couple of these topics. So let's talk about survival biases. Now, PSMA PET-CT is a new technology that's recently been innovated, and we know that if we use PSMA PET-CT compared to bone scans and CT scans, which is the current standard, we can see that there are management impacts in 28% of patients with PSMA PET-CT compared to 15% of patients with bone scans and CT scans in patients with intermediate and high-risk localized prostate cancer. Okay, so it looks like PSMA PET-CT is the way to go, except that might not be true, because if you look at the FDA licensing of another PET PSMA tracer, you can see that the impact on survivals and other outcomes remains to be determined. Okay, so do not assume that because you change management, you will change patients' outcomes. And in fact, this has been highlighted by many recent papers in high impact journal papers. This is one of the quotes. The quote says, "The value of imaging comes when it is shown that next generation imaging maximizes benefits or minimizes undertreatments, reduces overtreatments while tempering costs and toxicities when biases are taken into account." So what are these biases? What you have to remember is that we know that these next generation imaging technologies improve sensitivity. True. But that means sensitivity to indolent disease. That means sensitivity to microscopic metastatic disease. It also improves lesion characterization, in other words, specificity. But remember, all of these will lead to a number of biases, including stage migration bias, lead time and length time bias. So let's just talk about these biases very briefly. So let's say you've got conventional imaging and you divide patients into metastatic and non-metastatic, and if you treat them with a particular treatment, you can see that patients with metastatic disease have a worse survival than patients with non-metastatic disease. Then you introduce the next generation imaging technology. And what happens is you get bidirectional reclassifications. So this patient with false negative ends up on this side, this patient with false positive ends up on this side. Okay, so if you were to use the same treatments, what you'd see is not only do the non-metastatic patients improve, but the metastatic patients also improve in survival. Why did that happen? That happened because some of these patients with indolent disease have gone in here. Some of these patients with microscopic metastatic disease have gone in here. In other words, you've got a dilution effect. So because of this dilution effect, the overall burden of disease in this group is actually less, as a result of which, as a whole group, they survive longer. Clearly, this is a statistical aberration. Also remember that because you have treated microscopic metastatic disease at an earlier time point, if treatment intervention causes no additional survival benefits, then all you've got is lead time bias. So you diagnose something earlier, but the patient was going to die of it anyway. You intervened at an earlier time point. The survival is exactly the same. All you've got is this lead time bias by an earlier diagnosis. The other issue is length time bias. If you detect and you treat disease that would never kill, then what happens is you artificially improve survival of disease that would never have killed. So what's the point of that? And that's called length time bias. Now, of course, this is a statistical aberration. So stage migration is a statistical aberration related to higher accuracy. Only the perceptions are changed, not actually the disease state. And remember that overdiagnosis harms of indolent disease detection is a clinical management limitation, not a diagnostic limitation. So because you're not acting on the new information, you're just using the same treatment, then that's when you start developing harm. In fact, if you talk to the regulator, the regulators will tell you that there is no need to show management or outcomes impact for a test. However, if you start using the test for a claim, in other words, you're saying that you get better outcomes in these patients, these management changes result in improved survival. That's a management claim. Then you have to show that in a prospective clinical study focusing on relevant quality and quantity of life endpoints. And do not assume that a management change will necessarily result in a patient benefit. And this was shown in this paper published in 2012. Here you can see that patients with prostate cancer with spinal metastatic disease on a bone scan were randomized to either having an MRI or having no MRI. If you had an MRI, then if you found spinal cord compression, you can see 30% of these men were then offered preemptive treatment for what was asymptomatic spinal cord compression. If you follow these patients over time, you'll see that there is no difference in the outcomes of patients who had the MRI or those patients who did not have the MRI. You can see that the overall survival is no difference. You can see that the persistence of neurological deficits is no different. You can see that the future emergence of spinal cord compression is no different. In other words, just because you change management, in this particular instance in 30% of patients, does not mean that eventually patients benefit. So in fact, today we do not recommend preemptive MRI in patients with prostate cancer metastatic disease on the bone scan, because actually it makes no difference. So we wait for symptomatic disease. And this brings up the point of building clinical value. remember that at the moment in radiology we tend to stick to level 1, 2 and 3. We tend to go as far as thinking about diagnostic efficacy. Does the test help a clinician to think about a diagnosis? We sometimes now go on to what's level 4. Does the medical test aid in treatment planning, the management change? But remember that real value comes when you show improvements in patient outcomes and societal benefits. That's where the value really does increase, and that's what you need to do. So as you think about developing your own biomarker, you need to think about 6 steps that you need to go through. We don't need to go into the details of these steps, and I've discussed that in other videos on my channel, but these are the 6 steps that you do need to think about. But one point I did want to stress is that any imaging should enhance discrimination when combined with traditional biomarkers. So let's explain that in a few seconds. So how do you enhance discrimination? You do that by increasing benefits and limiting harm via biomarker integration. In other words, with other biomarkers. So we know that any imaging solution will have benefits that arise from its true results and harm that arises from its false results. So for prostate MRI, you've seen previously we talked about that the harm of false negatives, missing cancers, is less than 10%, which is considered acceptable when you look at the alternative, which is systematic biopsies. So less than 10% versus 30% of cancers that are missed. The biggest problem with prostate MRI at the moment is its false positive rate. In other words, too many biopsies are undertaken that result in either no cancer or cancers that are unlikely to kill patients. Now, can we improve the situation by integrating with other biomarkers? Now, it's possible to show that the PIRAD score, the suspicion score from an MRI, scales with the ability to find important cancers. So that's shown on the top on the left. On the right hand side you can see something called PSA density. PSA divided by the prostate volume, a simple biomarker. And you can see that too scales with the ability to find clinically important cancers. What happens if you were to combine the two of these together? Well, you'll end up with a graph that looks like the one below. Now, let's just think about this a little bit more. So let's say you were only going to see what the benefit and the harms would be if you used imaging alone. In other words, a positive MRI, PIRADS 3, 4 and 5. Well, the benefit you would gain is shown here. You can see that if you just used a positive MRI, you would avoid in this particular experiment about 40% of cancers, and you would miss 6% of clinically insignificant cancers, so less than 10% as we said previously, but the false positive rate was 45%. We said it was going to be about 50%. So this is exactly what we expect. Now, if you were to use this 10% risk threshold, I don't mind missing cancers less than 10% of times, that's what that means. What would happen if you just biopsied these negative men with a higher PSA density, these indeterminate men with a higher PSA density, and all the PIRADS 4 and 5 cases? Well, if you look at that, you'll see that the number of biopsies avoided is exactly the same as PIRADS 3, 4 and 5. Okay, so the benefits are maintained but not enhanced in terms of biopsy avoidance. If you look at the number of cancers that are missed, it's exactly the same. So in other words, you are not enhancing discrimination, but look what happens at the false positive rate. You see how the false positive rate in fact goes down by 6%. So that's a harm that is ameliorated by using MRI suspicion score and PSA density. A simple experiment to show you how you can use imaging with a serum biomarker to enhance discrimination, in this particular instance reducing false positives. Can you take that further? You can use a multivariable, you can develop a multivariable risk model to see if you can push this further. And in fact, it turns out that it doesn't really push it any further. So you can see that if you were to use a multivariable risk model in men who you were going to biopsy pilots 3, 4 and 5, the number of men with unproductive biopsies was still 6%. So in other words, going further than just adding PSA density to the MRI with a multivariable risk model doesn't really help further in this particular instance. You get the point that we're discussing. So here are my final discussion points. We need more innovations that solve problems. Clearly, innovation for innovation's sake is important, but we need a greater emphasis on innovations that solve problems. You design solutions by understanding and by engaging. Remember to think about integrating imaging into clinical pathways and controlling the flow of patients during their cancer journeys. Remember that imaging is not the only solution. It's part of the solution. You need to show the net benefits through biomarker integration all the way up the efficacy scale that we showed before. Remember, merely meeting the regulators in requirement does not mean that something will be clinically valued. You may show radiological value, consistency of interpretations, increased efficiency of workflow, etc., but that may not be valued by the clinicians in the clinic, whose focus is, of course, quite different. What they are trying to do is optimize the lives of their patients so that they would function better. In other words, you need to engage in studies looking at the clinical efficacy of your next generation imaging solutions, because that is what really provides the benefit that patients live better lives and function better. I hope you found some of these comments useful as you think about how you develop your own work. Thank you very much for listening.